So I wanted to talk about breast augmentation, and when you do a breast augmentation, you can put the breast implants in through three main ways. You can go through the armpit, which is called a transaxillary approach. You can go through the nipple, which is called a periareolar approach, and you can go underneath the breast along the inframammary fold, and they call it an inframammary fold approach. In my practice, I tend to do most of my breast augmentations through the inframammary fold, and the reason for that, there's some pretty good evidence that it's the lowest risk approach, and we'll talk about those risks. But if patients have a specific preference as to what approach they want, I do all three approaches, and they're all very reasonable as long as they understand the specific risks. So when you put a breast implant in, you can put an implant in two locations. You can do what's called a submuscular breast augmentation or a subglandular breast augmentation. And the muscle that we're talking about is the pectoralis major muscle. About 80% of my breast augmentations I put underneath the muscle, and about 20% I put on top of the muscle. The group that I tend to put on top of the muscle tend to be fitness competitors or bodybuilders, people that use their pectoralis muscle all the time and are very developed. The other group I tend to put more underneath the muscle, and there's really three main reasons for that. When you put an implant underneath the muscle, you have a lower rate of what's called capsular contracture. And with capsular contracture, what is happening is the body forms a thickened scar capsule around the breast implant. And in most situations, that is due to bacteria. And if you look at a woman's breast, bacteria can go from our skin and it can go up to the nipple, and the ducts of the breast can be colonized. And there are actually studies that demonstrate that. And the most common bug that we tend to find in the ducts of the breast are what is called Staph epidermidis, which is again a common microbe on the skin. And so when you put an implant underneath the muscle and you stay away from the breast tissue, you have a lower chance of getting bacteria on that implant. And if you do, you can get what's called a biofilm, which is it's this film that the body forms due to the bacteria. It's a protective mechanism, and you really can't clear it with antibiotics. And so capsular contracture rate historically was about 15% on top of the muscle, and if you put it underneath the muscle, it's about 5%. So again, that's reason number one, a lower rate of what's called capsular contracture. Number two is mammograms. So when you put an implant underneath the muscle, you only obstruct about 10% of the breast tissue, and when it's on top, it's about 30 to 40%. So you get a better mammogram. 1 in 8 women get breast cancer, and so mammograms are an important thing for breast health long term. And then the third reason is the muscle gives some soft tissue support over the implant. And so we've all seen women that have implants and you can see rippling. And I always say they look like beach balls underneath the skin. It's not a great look. The muscle gives some soft tissue coverage over that, and so you have a little bit less rippling. Now, the downside to having an implant underneath the muscle is you can have what's called animation deformity. So when the woman flexes their muscle, the implant will move out to the side. And if you have a very developed muscle, as say a fitness competitor or a bodybuilder, you can see that movement quite a bit. But for most women, it's just not that big of an issue. And I think the upside of having implants under the muscle outweighs the downside. But again, there's not really a right or a wrong answer, and it's a discussion I have with each and every patient. When we use implants, we use what are called gummy bear implants. And basically what that means is if you take these new generation implants and you cut them in half, the gel doesn't go anywhere. And so they're a much safer implant than the implants of old that were more of a liquid silicone. And that's, when you hear the term gummy bear, that's basically what that means, that you cut in half and it's gummy bear-like. When we place implants, we use smooth implants most of the time. The textured implants were associated with something called breast implant associated anaplastic large cell lymphoma. So it's a long name. And basically it's a lymphoma that is related to inflammation due to the texturing on this implant. And so there was one specific type of implant, the BioCell implant, that was taken off the market. And so by and large, we don't tend to use textured implants anymore. And the textured implants were associated with these shaped implants called teardrop implants. And we used them for a lot of years but they didn't actually work in patients as well as they look on the table. And so the smooth implants are not associated with the breast implant associated anaplastic large cell lymphoma. So that's predominantly what we use. Now, for a lot of years, there were saline implants, and we can still use saline implants, but it's very uncommon now. The other thing you have to talk about with breast implants is something called breast implant illness. And so there's been a lot in the news about this lately. And breast implant illness, or BII, is defined as non-specific autoimmune symptoms that patients feel are caused by their breast implants. Now, there's a lot of controversy regarding this illness because the science isn't necessarily there. And in most situations, women will say, you know, I had an implant put in when I was 25 or 30 years old, and now I'm 50 or 55 years old, and I'm having, you know, some myalgias, I'm having some back pain, I'm losing some hair, things like that. They're these kind of non-specific symptoms. And so, you know, a lot of patients will feel that the implants are kind of quote unquote making them sick. And what I always tell my patients is there's, you know, I think there's maybe a very small percentage of women that could be true, but there's not a lot of scientific evidence to back that up. And just like most medications, most people could take, say, an aspirin, and they do just fine with it. And a small subset of people could take an aspirin, they could have an allergic reaction. They could have a bleeding ulcer or something like that. And so, you know, BII, it's very prominent in the social media world right now. There's a big group on Facebook. You know, and when you look at breast augmentation overall, about 92 to 94% of women who have implants are happy with it and they would do it again. And so, you know, there's a lot of research going on with BII. You know, whether it's real or not, we don't quite know. The difficult thing is about 20% of women have autoimmune symptoms, whether they have implants or not. And so, you know, are the implants causing BI or not? Again, it's something that is hard to prove. It's something that I talk to every patient about. It's something that the FDA wants us to talk to patients about. But again, you know, the vast majority of women who have implants are happy with their implants and they would do it again. I have a device called Vectra, and Vectra is an imaging device that allows us to take a picture of the patient's breast and simulate what you look like with a breast augmentation, and this is an example of that. And so, you know, everyone has some asymmetry to a certain degree, and if you look at this patient, the left breast is maybe a little bit larger than the right breast. And so that's important to understand because sometimes it'll affect what size of implant or what type of implant you're placing from right to left. Now in this patient, we're going to select a 385 cc implant, and what the computer will do is it'll do a morph, and you can show the patient before and after the breast augmentation. So this is a preoperative view and this is a postoperative view. And if I turn the patient to the side, you can see that their breast obviously is smaller and now it's larger. And it's very helpful to do an overlay. So you can see the implant you know, increases the size of the breast. And there's a couple things I like to point out. So whenever I put an implant and I go through the inframammary fold, where I place that incision, I tend to place it lower than their existing inframammary fold because when that implant's in there, that inframammary fold drops down, and I want the scar to end up right in that fold so that it's hidden. And then if you look at this patient from different angles, you can see obviously the difference pre-op and post-op, and this is the patient's view. And if we separate that out, you can see the difference. And the goal of breast augmentation is a pretty breast, not an overtly large breast. And I think one of the mistakes patients make is wanting too large of an implant. And if you place too large of an implant, it can actually make your midsection look heavy. And so you have a patient like this who's thin and otherwise fit, it just makes their midsection look thick. So the other thing this computer program allows us to do is simulate what you look like with a bikini top on or a bra. And this will just do this morph, and you can see obviously the difference. And if you look at, this is kind of the patient's view, so pre-op and post-op. And so it's a very helpful device to have for patients to look at because overall it's very accurate. So breast augmentation is a surgery. It takes about an hour to an hour and a half. It's outpatient surgery. I do it at an accredited surgical center. The questions people often ask: how much time do I have to take off of work? Well, it really depends on what you do. If you have a desk-based job, people can have surgery on a Tuesday or Wednesday, go back to work on a Monday. You have discomfort with it. Whenever I do breast augmentation, I do some nerve blocks where I block the nerves called the intercostal nerves, and I block nerves that go underneath the muscles on the chest wall. And that makes it a much more pleasant experience post-operatively. The first 2 weeks, I just want you to walk around, don't want you doing any real physical activity. After 2 weeks, you can start to work out, but I wouldn't want you doing bench press or push-ups for about 6 weeks. Now, when you have an implant underneath the muscle and you start to work out, you can get some of that animation deformity, and that can be a bit odd for a period of time. And usually after about 3 months, that gets better. The scars associated with it are basically hidden. It takes about a year for scars to fully heal, but usually after about 6 weeks, they're very, very minimal. So what are the risks of breast augmentation surgery? Bleeding in the first 24 hours, if it happens, that's when you see it. It's important to be off blood thinners, supplements preoperatively. Nipple sensation. So when depending on the approach you take, you can have a higher or lower risk of having the sensitivity of the nipple be affected. Most of the time, sensation to the nipple goes back to normal over time, but having permanent or temporary numbness of one or both nipples is a risk, and it could be temporary, it could be permanent, but again, most of the time that gets better. Breastfeeding. If you have breast augmentation, most women should be able to breastfeed, whether you put it under the muscle or over the muscle. If you have things like a breast lift or a breast reduction, that's going to affect your ability to breastfeed more so than just an augmentation. Implants. So implants are not permanent devices. At some point in your life, you'll need to have another operation, and that could be 5 years, that could be 25 years. They used to tell patients every 10 years you have to change implants out. There's no evidence to back that up. And I think as plastic surgeons, we do a much better job now following patients. I like to see my patients every year. I get ultrasounds periodically to look at the implant, to look for any fluid collections around the implant. And if there's anything abnormal on an ultrasound, you get an MRI. But having follow-up with your plastic surgeon is important. The scars associated with it, again, those heal very well. And then, acute things with surgery, anesthetic risk, nausea, vomiting, 1 in 4 people have that. Death with surgery, I always tell people there's a risk. Every time you get in your car, there's a risk of death, but you get in your car and you drive every day. So breast augmentation is a very, very safe surgery overall.